This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to and Happy New Year. Welcome to Friday Fellows Conference, the first of the year. Our speaker this morning is Dr. Rahul Patel. Those who haven't met Dr. Patel yet, he is a first-year fellow in the clinical track at his medical school in Texas at UT San Antonio, does residency here at Emory, and he is going to talk to us today about endomyocardial fibrosis. Dr. Patel, take it away.
Thank you so much, Dr. Williams. Thanks for everyone who joined this morning and who continues to join. This case is and discussion is a very interesting one for a condition that up to about 2 weeks ago I'd never heard of, which is endomyocardial fibrosis. And I wanted to give a special thanks to Dr. Mohammed Naeem. He's one of Emory's and Grady's cardiothoracic radiologists. He was very gracious this time to explain the condition and to go through the imaging that our patient had. I think that was fundamental for me creating this presentation. I have nothing to disclose. The only thing I wanted to bring up before I actually start my presentation is there was a presentation from one of our co-fellows just last year, Dr. Mariana Garcia, presented on hypereosinophilic syndrome. And that is a closely related condition, which I'll cover later in the presentation. And I think it's a fantastic presentation about this similar condition. In terms of my objectives are to present a case that will hopefully raise awareness about EMF, or endomyocardial fibrosis, which is a leading cause of restrictive cardiomyopathy in the developing world. I want to review the prevalence as well as the etiology of EMF and explore the pathophysiology, the role of multimodality imaging, as well as current management strategies for EMF. And then the last thing is I want to briefly discuss nutritional deficiencies that are associated with tropical heart disease. I think the big thing that I want to say is that this condition EMF is quite prevalent across the world, but it's actually very poorly understood. Since its first discovery in 1948, I've read that there's been less than 10 clinical trials for it. So it's not super well described, especially in the treatment aspect, but it's something that I think awareness will be super helpful for. So I'll start with my case. This was a case that we encountered at Grady just a couple of months ago. It's a 54-year-old female who presented with fevers, chills, abdominal pain, as well as increased somnolence. She was born and grew up in Nigeria and only moved to the US in the 2010s when she was in her higher 40s in terms of age. In terms of her prior cardiac history, she had a history of rheumatic mitral stenosis. That was first diagnosed actually in 2020. The story there was she had a COVID infection, of course, and then was found to have a large pericardial effusion. And then when the echo was done, they found that she had what initially was mild to moderate mitral stenosis. And then she's had serial echoes. And then early in 2023, rather, it progressed to severe mitral stenosis. So it went from mild to moderate to severe over the course of about 3 years. She also had a diagnosis of severe pulmonary hypertension with moderate tricuspid regurgitation, as well as restrictive cardiomyopathy, a chronic large pericardial effusion, and then she had valvular atrial fibrillation and flutter. And the last thing is she had sick sinus syndrome with a history of possible syncope. And that's relevant because she's had two big cardiac procedures. The first one was in February of 2023, when she had a bioprosthetic mitral valve replacement. She had a tricuspid valve repair with a 28mm annuloplasty ring. She had a Cox-Maze procedure for the valvular AFib, and then she had drainage of that very large pericardial effusion. And then later, just slightly before she presented this time, she actually had an attempt for a leadless pacemaker implantation. That was because of that sick sinus syndrome. What was really interesting is that despite multiple attempts to place the device in multiple aspects of the right ventricle, it was unsuccessful. There was failure to capture, as well as sliding the device. And so again, there were multiple attempts to place it, so much so that the manufacturer was actually contacted for what appeared to initially be device malfunction, and they had no answer as to what went awry. In terms of her presentation, so on presentation, she was febrile. She had a temperature of 39.6 Celsius. She was tachycardic to 120 and had a normal blood pressure. It actually shortly after did go down to like the 90s over 60s, and she was sitting well on room air. And then on her exam, she looked pretty tired. She spoke very short sentences, and she was diaphoretic. She did not have jugular venous distension. She was tachycardic. She had a 2 out of 6 holosystolic murmur at her apex and was warm peripherally with no edema. And then I think the other thing that should be mentioned is on her skin. She recently had that pacemaker implantation attempt, and she had a right femoral access site that had a small punctate tract. It wasn't closed, but it was also not purulent. There was no drainage. It was non-tender. The only thing is there was just a 1 centimeter area of induration. I will mention that she had just about a week before presenting this time with these fevers, had actually gone to the device clinic and was given doxycycline. So this presentation occurred after 1 week of doxycycline for a very questionable skin and soft tissue infection. And then this is her EKG. This was obtained after she received some fluids. As you can see, her heart rate was only in the 70s. It's really a relatively unrevealing. It's a sinus rhythm. And there may be a possible U wave that you see in lead 2, but it's really kind of unrelated. Her electrolytes do not have any sort of strong abnormality that would have caused this. Going to that, on her labs, in terms of her BNP, the one to mention is her creatinine. She had a creatinine of 1.8, which is increased from baseline of 1.1. From her CBC, her white count was 11, and her hemoglobin was 11.7, and then her platelet count was 95. She normally had a normal platelet count. Her BNP was 237, her troponin peaked at 89, and her CRP was very elevated at 140 with an ESR that was normal. And then the last thing, and probably the most important of all of her labs, is that her blood cultures were immediately positive for group B strep or strep agalactiae. Those were in 2 out of 2 sets that were collected in the emergency room. To give a timing context, they were collected at about like 10 p.m. And then by 8 a.m. the next day, they were already positive. So a very significant amount of bacteria that was present. And I've given the susceptibilities below. You'll see that it's ceftriaxone sensitive. So I'm going to go through the imaging in sequential order. So kind of to go through our thought process for what was actually a quite confounding case. The first thing that she had in the emergency room is she had a CT-PE protocol. And the interesting thing is, of course, she did not have a PE, otherwise I would have said that earlier. But she did have a couple of things that were unique, especially in context of EMF. She had a pericardial effusion. And then in the orange border, what you'll see is that she had what looks to be obliteration of the RV cavity with a V-shaped configuration. She also had a pretty smooth contour of the LV myocardium. And what you can really see here, without debate, is that her atria are quite enlarged in relation to the size of the ventricle. So she's biatrial enlargement. That is suggestive of restrictive cardiomyopathy. Going to her echo, we actually expedited the thoracic echo when the blood cultures were negative or positive, I apologize. And you'll see that on the apical 4-chamber view, her EF is normal at 60 to 65%. But what we do have is a couple of things that are interesting. I'll start with the picture right here. It looks like she has obliteration of the RV apex with a shrunken right ventricle. She has a flattened septum that's actually pushed over to the left side. That we've noted for a couple of years for her. She has the bioprosthetic valve, of course, the mitral valve, which with the leaflets that might be slightly thickened. And she had just mild MR, which is, I think, reassuring or not as concerning in the setting of acute bacteremia. And I think the thing that we can easily take away from this echo, she does have biatrial enlargement. These atria do look quite large in relation to the size of the ventricles, respectively. Going to the apical 2-chamber view, this is a little off axis, but the only thing I did want to point out is she may have some signs of left ventricular endocardial scarring. It's a little tough to say, but there does look like there is a little bit of brightness on that border over there. And then the last thing is in going on the peristernal long axis view, what we do see here quite clearly is that even though her RV apex was obliterated in the prior view, we do see a very large right ventricular outflow tract. And so that has been there throughout the years for her imaging. And then on a more zoomed in view, what we'll see over here is that one of the struts of the bioprosthetic mitral valve comes pretty close to the LVOT. And so it does put her at risk of getting subvalvular aortic stenosis from that. Because of all of these things, we ended up moving to a TEE because the TT was not descriptive of anything that was super concerning for endocarditis. And I think, fortunately, the bioprosthetic mitral valve did look pretty good. It had good function. There was no vegetation on it. And there was also really no significant mitral regurgitation that she had on it either. So that was good news because she, again, had group B strep bacteremia. And one thing that she did have, which was actually quite interesting and brought up a lot of conversation, is if you look right here, she appears to have a Doppler that goes in a very unusual location. And this is in the aortic outflow view. And so because of that, we actually had a concern for a phenomena that was called the Gerbode defect, which is an abnormal shunt between the left ventricle and the right atrium. Generally, this condition can be either congenital or acquired. Our concern here would have been an acquired one from a biprosthetic valve endocarditis. And so this finding led to a lot of conversation. I think the thing that we thought that may have been reassuring was that her shunt was not continuous cycle. Again, if it's LV to RA, you would typically expect it to be present in both systole as well as diastole. Hers does not appear to be that case. So given that information, we actually pursued a cardiac MRI to look for possible shunt physiology and to provide us with a definitive diagnosis. And so that's what we obtained next. So I'll go to the cardiac MRI. This is a 4-chamber long view. And what we see here is that she has, again, kind of like what the CT shows, obliteration of her RV cavity with smooth LV myocardium, as well as moderate to severely dilated atria. All the atrial dilatation, again, is being concerning for the restrictive cardiomyopathy. This is a pretty interesting image. So she actually had a prior cardiac MRI in 2020. That's on the right side, as well as the newer one in 2023. And what we see here on this perfusion scan is she has a thin linear chronic hypoenhancement here that we see in the red arrows, which are suggestive of chronic linear thrombus or scar in the right ventricle, which is very suggestive of endomyocardial fibrosis. And this is a right ventricular inflow tract view of the MRI from 2023. And what we see here is, again, we see that she has this obliteration of the RV apex, but she also has dilatation of her right ventricular outflow tract. That is the same phenomenon that we see in her personal long axis echocardiography view. Another image right here is that she has, again, the apical obliteration of the RV. So small RV, if you look in the apical 4-chamber view, with the RVOT dilatation, and she also has dilatation of her main pulmonary artery. This RVOT and PA dilatation has been present since 2020, but we see that it has expanded over the years, which is suggestive of worsening pulmonary hypertension in the 3 years or so in between. And then the last view that I'll show from the MRI is that she has a dilated IVC that actually did not collapse, as well as a pleural effusion. So the read in the MRI was that though it was limited, she did not actually have an intracardiac shunt. So she, her QPQS was 1. That was all not suggestive of the Gerbode defect. It turns out it was just artifactual. And it might have been artifactual because she had a lot of LVOT narrowing, and there may have been a Doppler that was in an abnormal direction that we were picking up in the aortic outflow view. And what she did have, as I showed earlier, was this obliteration of her right ventricle with sequela of RVOT dilatation that's likely from pulmonary hypertension. In terms of her hospital course, she improved quite quickly. I think it's very good news. She was treated with IV ceftriaxone for the group E strep. Although her first 2 cultures are positive, or her first culture, 2 sets were positive, she ultimately had several negative blood cultures after that. The source was actually something that we never fully teased out. Traditionally, group E strep has been associated with urinary tract infection, but her her UA rather, was actually negative. The alternate is a skin and soft tissue infection. I mentioned that she had a recent pacemaker attempt from a femoral access. We actually tried to do a lot of imaging off that, and there was actually no significant fluid collection. There was really no enhancement there, so it was not clear what it was. It may have been the SSTI versus the UTI. And then she did so well that her renal function actually returned back to baseline prior to discharge. So that brings me to my conversation for today, which is endomyocardial fibrosis, which is abbreviated to EMF. EMF was first described by Davies in Uganda in 1948, and it is a leading cause of restrictive cardiomyopathy in the world, especially in developing nations. It's predominantly found in tropical, lower income countries. And I think the big thing, including with our case, is it requires a very high index of suspicion. The characteristic features the following. You get apical predominant obliteration of both ventricles that includes fibrotic changes within the endomyocardium. You also get valvular fibrosis with associated mitral and or tricuspid regurgitation. And then you get the biatrial enlargement. And I think you see that here where you get this is the apical obliteration, and these are the large atria right there. The prevalence of it. So there's an estimation that I read in one review paper that they say about 10 million people globally have the condition. This is likely an underestimate. And the reason why is because it depends at what stage you diagnose the patient. The 10 million may be people who have florid fulminant heart failure in the very end stage. But there was actually an interesting study in the 1990s in Mozambique, one of the endemic areas. And when they used echocardiography in a traditional rural area that this has a high prevalence in, they found an estimated prevalence within that area of 20%. So if you catch people earlier in the condition, you can get 20% of many rural areas that are tropical. So that would put that 10 million number likely higher. The key demographics that are implicated are nations that are tropical. And within these nations, these are the rural, humid, and low-lying areas. It affects lower income individuals. And there may be a bimodal age of distribution, the first being a peak at 10 years of age, and the second one being at the 30 years of age. On the right in this image, you just kind of see what the tropics are. It's just a belt right there. And these are the countries, again, that are that have the highest prevalence of EMF. And those countries include, in sub-Saharan Africa, it's Uganda, which has some of the most described cases. Again, the condition was initially described here. Mozambique, which I described that study that showed about 20% prevalence in one rural area, as well as several different nations in West Africa, most notably Nigeria, as well as Equatorial Guinea. In India, in South India, there's a state called Kerala that has a very well-described high prevalence. In China, there's one southern state province called the Guangxi province. And in South America, the two countries that have the highest prevalence are Brazil as well as Colombia. In terms of the etiology, there are a lot of theories out there, and it's not really clear what the culprit is. I want to be very, very clear about that. It's poorly understood. It's likely multifactorial, but the described theories are that there's a role for parasitic diseases as well as eosinophilia, and these two are closely linked. There is a potential role for diet and nutrition to cause EMF, and then the last thing is genetic predisposition as well as the inflammatory hypothesis. So I'll start with the parasitic diseases hypothesis. What we know is that there's a high prevalence of parasitic diseases in areas that are endemic with EMF. And the parasites that have been implicated include malaria, schistosomiasis, filarial infections, including loa, as well as strongyloidiasis. And the thought is that the parasitic infection may actually trigger autoimmunity as well as eosinophilia, which can ultimately lead to the EMF changes. There are two big limitations of this parasitic theory. The first thing is that if you look at patients who have EMF versus patients who are normal, there is no difference in their parasitic load. And then the second one is that areas that traditionally have parasitic infections that are associated with either eosinophilia or other pretty significant pathology, for example, schistosomiasis and pulmonary pathology in Southeast Asia, have a very low incidence of EMF. So they may have other manifestations of parasitic infection, but not myocardial fibrosis. And so that's a pretty important caveat right there. In terms of the closely related hypereosinophilia theory, eosinophilia is actually very interesting because eosinophils are associated with four things. They're associated with IgE-mediated inflammation. They're associated with thrombosis, vasculitis, as well as fibrosis of tissue. The two limitations for the whole hypereosinophilia theory is that eosinophilia is only observed in the early stages of EMF, and even then it's inconsistently. So if you in one study where they looked at patients with early stages EMF and they actually did like peripheral assessments for eosinophilia, the presence ranged from absent to only about 70% prevalence of eosinophilia across various cohorts. And that's a big range. It's also not like 100% there. And the other thing that might be even more notable is that there was one cohort in Uganda where they took 49 patients and did endomyocardial biopsies of fibrotic tissue in patients with EMF, and 0 of those cases actually found any kind of signs of eosinophilia or the sequela of eosinophilia. And I think that's pretty important. In terms of the etiology from a dietary perspective, there's two thoughts. The first one is that patients in these areas have a very low protein diet. And so they have a risk of what's called cerium-mediated endomyocardial fibrosis. Cerium is one of the rare elements, and it can lead to fibrosis. The other one, which has actually a lot of data in it from different parts of the world, is cassava or the yucca root. So the cassava, which the picture demonstrates to the right, is a low-cost, carb-rich tuber. It's used in many parts of the world because it's cheap, and it's a lot cheaper than rice or corn. And the issue with it is that raw cassava contains cyanogenic glycosides. So if it's poorly prepared, then they can actually liberate hydrogen cyanide in the gut and can lead to chronic cyanide toxicity. And then the manifestations of that would be either neuronal toxicity or myocardial fibrosis. It's actually interesting because I was actually taking off in this country too. If you go to Costco, you'll actually see some chips of cassava in them, but those are of course well prepared. But it's just in many parts of the world, it's actually the predominant carbohydrate source. There are two theories that may actually, or two cases rather, that may suggest link with the cassava theory. In Kerala and South India, what they found is that improvement in socioeconomic status, as well as a drop in cassava intake because of rise in income, have led to reduction in EMF prevalence and incidence. And then there was a very small experiment where they fed a couple of monkeys a cassava pure diet, uncooked cassava, and then they fed their peers raw banana plant, and they found that the monkeys that were fed cassava were much more likely to induce EMF-like changes in their myocardium. And then the last theory is like genetic or acquired factors. This is also very poorly understood. There was one paper that came out several years ago where they tried to compare MHC classes of EMF patients with their ethnically matched controlled subjects. And what they found was that in a Mozambique cohort, there was a higher incidence of HLA-B58 amongst patients who were EMF positive. And in the Ugandan cohort, there was a higher incidence of this HLA-A202. Again, this is not, there still doesn't explain how 48 and 65% respectively did not have either of these HLA classes, but it just shows that there may be a genetic or inflammatory component. And then the last thing in terms of acquired factors is very early in this disease, in the history of the disease, they found that foreign expats who had previously lived in South Africa in tropical parts, when they returned back to Europe several years later, they actually developed EMF. And so it's not like they developed it while they were in South Africa per se. And it just is kind of suggested that social deprivation may not be the only factor that's associated with EMF. And it's not clear why these people developed the condition. It may have been dietary, it may have been parasitic. We really don't know. In terms of the pathogenesis of the condition, there's three phases. The first one is the active one. The second is a transient progressive one. And the third is a chronic phase, which has restrictive heart failure. In terms of the active phase, it starts with an acute febrile illness, and then that leads to a lot of nonspecific symptoms. Those can include dyspnea, paraorbital swelling, or even pancarditis. And the pancarditis, of course, is the one that concerns us the most. There's a lot of nonspecific changes on the EKG. You may see low voltage, you may see conduction or repolarization abnormalities, and on an X-ray, you may see effusions, either pericardial or pleural. Histologically, the thing that occurs is there's eosinophilic microabscesses, and these will lead to thrombosis of the endocardium with endocardial thickening, as well as possible thromboembolic events. The transient progressive phase is one that's actually a little bit debatable, but what we do know is some patients quickly go from an active phase to a chronic phase, and some go from an active to a chronic phase over decades. Like, for example, our patient who grew up in Nigeria and only in her higher 40s actually developed what may have been pathologic EMF-related heart failure. And in terms of the chronic phase, what we know is that patients that have restrictive heart failure, again, it's the #1 cause in developing nations. And this has a couple of features. The first one is fibrosis of the myocardium as well as the valvular apparatus, which can lead to several things. It can lead to atrial fibrillation, which 30% of patients are estimated to have, as well as ventricular arrhythmia, which can be one of the leading causes of death. Patients can get pulmonary edema as well as pulmonary embolism. And one interesting thing is you can have right ventricular predominant EMF. And that's actually what our patient has. If you look at the MRI as well as the CT images, her RV is far more involved than her LV. And the RV EMF can lead to ascites that's disproportionate, as well as hepatomegaly and splenomegaly. The big thing is that the chronic phase with restrictive heart failure has a very poor prognosis. Estimates are that there's about a 75% mortality at 2 years, so it's pretty bad. This kind of shows some of the features. The first patient on the left side has really, really prominent ascites, and he also does not have significant lower extremity edema. He just looks quite malnourished. You know, you could alternate diagnosis, though, to a less profound degree in many parts of the world would be something like kwashiorkor. And then in the middle image, you'll see that there's obviously cardiomegaly in this 10-year-old young female with left-sided predominant EMF. And what you see is that she has a very giant left atrium right here with associated severe MR. The image on the right is also a young patient, a 12-year-old male with a right predominant EMF. And what you see is he has cardiomegaly too, but he has an aneurysmal right atrium. So these are kind of the two sides. You can have left predominant, you can have biventricular, or you can have right predominant, but the right predominant typically causes that very large ascites. So I touched on this earlier. EMF is oftentimes described very similarly to a related condition called hypereosinophilic syndrome. I think the big thing is they present very similarly, but they have some differences, especially when you look at etiology and pathophysiology. So hypereosinophilic syndrome is oftentimes called low floors endocarditis or non-tropical eosinophilic endomyocardial fibrosis. And again, they're nearly identical, especially when you start getting fibrosis. They're basically indistinguishable. They have a triad of acute inflammation, followed by thrombosis, followed by fibrosis with that restrictive cardiomyopathy. But the differences include the following. I think the biggest thing is the location. So EMF is a condition that's associated with endemic, tropical, lower income areas, which is HES, hypereosinophilic syndrome. It's a non-tropical disease, and that's actually reflected in the name. Eosinophilia is actually part of the diagnostic algorithm for hypoeosinophilic syndrome, whereas in EMF, as I mentioned, it's not always observed. In terms of disease associations, HES is frequently associated with leukemia as well as allergic or atopic conditions. And hypereosinophilic syndrome is also a condition that typically progresses faster, whereas EMF is oftentimes more indolent. And then the role of corticosteroids is a very interesting one. Hypereosinophilic syndrome is thought to be a condition that is very responsive to steroids, and steroids actually are the first line in management. And what we do know now is that tyrosine kinase inhibitors, as well as anti-interleukin-5 monoclonal antibodies, are having some role in terms of management, whereas in EMF, the role of corticosteroids is very debatable and questionable. There's really just like anecdotal case reports. And so this image kind of shows that further, where this is 302 patients from the National Institutes of Health that were referred for hypereosinophilic syndrome. And what you see is that a lot of the patients actually have myelocytic hypereosinophilic syndrome or lymphocytic predominant hypereosinophilic syndrome. If you look at the small pie over here, these are the associated conditions for which elements are right there. So it's really a very small part of the pie that is actually associated with parasitic disease that in this NIH cohort had HES. Whereas this is thought to be the predominant risk factor for EMF across like the board. So now we'll move to like, how do we actually assess EMF? And we use multimodality imaging. The first one is echocardiography. Echo, as we all know, is benefited by its wide availability as well as low cost. The limit of echo is that tissue characterization is quite difficult. What we are able to do well is obtain morphologic assessment. So we can see that the patients typically have shrunken ventricles and atrial enlargement. And then we can also do Doppler assessment. So with color Doppler, we can assess for regurgitation. And when we use PW, we can actually assess for restrictive filling patterns, especially in the advanced stages of the illness. Cardiac MRI is the gold standard for diagnosis of EMF. It's limited by the fact that patients are oftentimes in areas with, again, limited healthcare infrastructure, and MRI may be difficult to obtain. But what the MRI does do very well, in addition to morphologic assessment as above, is it does a great job with tissue characterization. And so we can truly visualize fibrosis as well as apical thrombosis in a way that echocardiography may not be able to provide. And then the last thing from imaging and diagnosis is endomyocardial biopsy. Biopsy used to be, up until like the 1980s, the standard of care, but its yield is actually quite limited. Only about 50% in patients were later found to have EMF. And thus, it's not frequently used. It's very invasive, and it just doesn't have a high yield. And below on the table, the cardiac CT is emerging. We actually ended up using it for our case. And again, it was a CTP protocol, but it did show some of the changes that we can that have been associated with EMF. So I'll start with echo. There actually are defined criteria for the diagnosis as well as assessment of the severity of EMF. The changes that we should look for are the following. In image A, what we can see is that there is soft echogenic infiltrates within the left ventricle with two following changes. The first thing is you have scarring of the endomyocardial that is right here with inflammatory changes. In image B over here, you'll see that there's again a shrunken left ventricle with scarring that you can see right there that's highlighted. In image C, you have RV predominant EMF with again that apical obliteration, which leads to probably the most significant of all images, which is image D over here. This is severe biventricular EMF. And what we see is very clear sequela of restrictive cardiomyopathy, where you have obliteration of both of the ventricles, left here, right here, and you have biatrial enlargement in these two pictures over there. And then in this last image, again, this is RV predominant EMF, and you see a very, very, very small right ventricle with ballooning of the right atrium. I'll move next to cardiac MRI. These are pictures that were published by a group out of Brazil. And this is a moving cine image of a cardiac MRI of a patient, a 27-year-old patient with biventricular EMF. And what we see over here, again, is she has apical obliteration of both ventricles. This is the right over here. This is the left over here. And then if you look at her DE image over here, you'll see she has something called a double V sign. And the double V sign, if you go from outside to inside, includes the following. You have normal myocardium over here, followed by fibrosed myocardium over here, followed by on the most inside, you actually have thrombus. And so that is seen in both EMF as well as hypereosinophilic syndrome, this double V sign. And then there are some criteria that have been published or put out for MRI findings that might be suggestive of EMF. In terms of how do we manage the condition, this is where several more of the caveats come, including the fact that the data is incredibly limited. There have been very few trials, let alone randomized trials with large number of patients for this condition. And what we do know is that no medical treatment has any proven survival benefits. So what we can offer may be able to only help symptoms at best. I think one of the bigger issues, in addition to the fact that we have not allocated a lot of resources towards this, is that patients also present frequently in the later stages of the condition, where they have advanced fulminant heart failure. So the medical management is the following. The first two are the big ones, are diuretics and ACE inhibitors. Diuretics do yield a symptomatic benefit, as well as ACE inhibitors. There's thought to be a symptomatic benefit from ACE inhibitors. The interesting thing is that there's no data that shows that ACE inhibitors can actually have an anti-fibrotic role. This is in contrast with other fibrotic conditions, such as like muscular dystrophy, where there's actually some studies that shows that ACE inhibitors can actually halt or even possibly reverse fibrosis. The next thing is paracentesis. Paracentesis does have a role, especially for patients who develop ascites. And that leads me to corticosteroids. Corticosteroids are very debatable. We know that there's absolutely a role for its associated hypereosinophilic syndrome, but for EMF, the role of prednisone is probably just anecdotal. What we do know, there was a paper that actually looked at, do corticosteroids actually reduce the reaccumulation of ascites? And the answer to that is no. So if you could use it, it's possibly only patients who have the very acute carditis form of EMF, but once they progress to chronic, there's probably no role whatsoever for it. And then the last thing is anticoagulation. There would be two possible indications for anticoagulation in EMF. The first one is atrial fibrillation, and then the second one would be intracardiac thrombi. Just like all the others, there's no trials that actually assess whether warfarin or DOAC have any benefit, but patients who have these two indications would probably benefit from anticoagulation. The only thing that actually has some validated data is surgical management. And the surgery that is chosen for EMF is called endocardial decortication with associated valve repair or replacement. So the picture on the right actually shows that. It's from a case where they performed an endocardiectomy. That's showed on the histologic cross-section right here. You actually remove the fibrotic endocardium, and the blue dye over here shows the myocardial interface. And what you try to do is leave behind the underlying healthy muscle. The thought here is that if you can take off the fibrosed tissue as well as associated thrombi and leave behind the healthy muscle, you can lead to improvement in the restrictive cardiomyopathy that the patients may have. This surgery is oftentimes, though less so recently, performed with mitral or tricuspid repair or replacement. The issue here is that patients often have mechanical valves because they're so young when they have the surgeries. And the maintenance of these valves in resource limited settings is very challenging. The INR checks that are associated can be hard to do. So that's why if the patient is able to have the endocardiectomy without the valve replacement, that is the preferred strategy. This surgery is the best option for patients with class 3 or class 4 heart failure because it reduces symptoms and may even reduce mortality. There's some data that suggests that it does. The two big important things to mention for it is it's very high risk. The early postoperative mortality ranges from 20 to 30%, and it requires experienced centers. And that's probably the biggest issue of all is you have patients who are in areas of the world that struggle to provide some of the most basic healthcare infrastructure, and then you require a very experienced apparatus to perform this surgery as well as the postoperative care. The other surgical management strategy that could be offered to these patients is cardiac transplantation. The evidence for this is very poor. It's anecdotal, so there's just not much data about it. And of course, you'd have to screen them for pulmonary hypertension that may make them not a candidate for this cardiac transplantation. So I just wanted to circle back to our case. So our case is actually an interesting one. Again, she initially was diagnosed with mitral stenosis that was mild to moderate back in 2020. The story there is she had COVID, had a pericardial effusion, and then her EF was normal, but she had this mild to moderate mitral stenosis. What we did know also was that she had a moderately to severely dilated RV with bowing of her septum. And so that prompted a TEE, which again commented that the mitral stenosis was only moderate with a mean gradient of 6. But what she did have was severe RV dysfunction and moderate PA dilation. And so at that time, we actually pursued a right heart cath for her. And the right heart cath showed the following, where her RA pressure was 8, her mean PA pressure was 30, and her wedge was 15, so transpulmonary gradient of 15. Cardiac output and index were actually fine. Her index is 3.1. But in looking back at the notes, there was this RV dysfunction that was not fully explained. And I actually copied from the note where the thoughts that she may have had pulmonary microthrombi, she may have had COVID myocarditis, or ARDC. And for those reasons, we actually several years ago recommended a cardiac MRI, which showed that she did have biventricular diastolic dysfunction, as well as biatrial enlargement, all signs of restrictive heart disease that was unexplained in terms of its etiology. And then, we ultimately found that maybe she just had rheumatic heart disease that might have led to this condition. But EMF was not really caught because we didn't have an index of suspicion at that point in time. And then earlier this year, or 2023 rather, when she ultimately did have worsening heart failure and a very large pericardial effusion. And that's at that point in time, she had what was determined to be severe mitral stenosis with a mean gradient of 12. And again, her RV remained dilated. And that's when she had the surgical correction, where she had the mitral valve replacement, the tricuspid valve repair, as well as the drainage of her pericardial effusion. And I want to be clear, this was probably very helpful for her because after that very large surgery, she had no following heart failure hospitalization. So she actually had a quite successful 2023 up until she had the bacteremia. Again, very fortunate that she did not get endocarditis from the bacteremia. So putting it all together, this is a lady who grew up in Nigeria, had what was initially mild to moderate mitral stenosis with severe RV dilatation that was out of proportion to that. And so what she probably had, especially given her the fact that she grew up in Nigeria, is 2 hits where she had mitral stenosis that was, again, not initially severe, and she likely had EMF, right? EMF, which is RV predominant. The big thing is that we actually, for this reason, we tried to get MRI, and it wasn't described there. But if you look back and try to Monday morning quarterback the case, you see that she does have the fibrosis at the early stages. And the other thing that was really interesting in her case is that she had this attempt for pacemaker implantation just 2 or 3 months ago. And despite multiple attempts to place the pacemaker in multiple parts of the right ventricle, there was failure to capture. And so that failure to capture was not actually a device malfunction. It was really a reflection of her having a very fibrosed myocardium, and it was just very difficult to pace that. And I want to close by just talking about nutritional heart disease. So there's several different vitamins that have been associated with nutritional heart disease. The 3 that I'll talk about are B1, severe vitamin D deficiency, as well as selenium, which is an element. I think the big thing here is, unlike EMF, which has poor outcomes data, these vitamin deficiencies are actually quite responsive to supplementation. So the important thing is to diagnose it early. The first one is the one that we'll probably see the most within the United States is B1 or thiamine deficiency. So thiamine is very interesting because it's a cofactor in a lot of different metabolic reactions, including the Krebs cycle, where it helps convert pyruvate to acetyl-CoA. And if you don't actually have the thiamine as a cofactor, what happens is you shunt the pyruvate off to the lactate cycle, and you don't actually enter the Krebs cycle. So you need it for oxidative phosphorylation. The sources of thiamine deficiency include the following. The first, especially in low intake areas, is just low intake because patients eat polished, unenriched grains. So if you dehusk the grain, then you don't actually have the thiamine. And so the FDA has actually mandated that if you have enriched flour, it should have both thiamine as well as folate. And we know about folate for the pregnancy and the neural tube defects, but thiamine is also very important for the enriched flour that our country supplements by law. The other sources are poor absorption, and we'll see these in patients who are alcoholic or patients who have gastric bypass and don't take their vitamins. And the last one, which is interesting for our viewers, is losses. So diuretics can lead to urinary losses of thiamine, and so patients on very high dose diuretics for years may actually have a thiamine deficiency. And so in terms of the cardiac manifestations, there's two of them. The one that's better described is the wet beriberi that we've probably heard of, which is that classic high output heart failure. And the thought there is that the cardiomyocytes, the mitochondria, don't have enough energy input or energy units. And so you get a lot of oxidative stress and you get reduced myocardial energy reserve that can lead to several things, including high output as well as reductions in the systemic vascular resistance. And over time, that can lead to reduced LV as well as RV function, tachycardia, as well as edema and jugular venous distension, all signs of heart failure. The other form, which is a far more acute form, is this described Shoshin or acute beriberi that is a low output form, where patients will present very quickly with fulminant heart failure as well as lactic acidosis. The diagnosis, this is a learning point for me. I think especially in residency, I frequently send out B1 lab and hope it would come back and then try to treat them. But the interesting thing is thiamine levels, that one that I was sending out, does not correlate very well with whole body or total body thiamine levels. What is the gold standard is actually testing for its functionally active form, which is TTP. Unfortunately, that testing is not very readily available. And the big thing is that if you suspect and you treat patients for thiamine deficiency, their cardiomyopathy frequently reverses. And so the recommended dose is 200 milligrams IV or TID or PO 3 times a day until symptoms improve. The other two vitamins that are associated with heart failure are vitamin D, and this is the severe form. So patients with rickets can get hypocalcemia-induced dilated cardiomyopathy. And selenium, this is a rare element that we don't frequently think about. It can be associated with a condition called Keshan's disease that was initially described in China, where patients can actually, who are selenium deficient, can have an increased susceptibility to Coxsackie B virus, and thus its associated dilated cardiomyopathy. The other thing that selenium does is if you're deficient, you can have endothelial dysfunction with increased atherosclerosis long-term. So just bringing it all together, endomyocardial fibrosis is a leading cause of restrictive cardiomyopathy in the developing world that's frequently found in tropical lower-income countries. This etiology of it is truly unknown, but the mechanisms include parasitic disease with associated eosinophilia, as well as nutritional sources like cassava. And the characteristic features include obliteration of the ventricles, typically at the apexes, from fibrosis and the overlying thrombus, valvular fibrosis, and then the biatrial enlargement that is suggestive of restrictive cardiomyopathy. The prognosis of the condition is very poor, and there's really limited medical management. The two that are best described are diuretics and ACE inhibitors. Surgical endocardial decortication can be performed at experienced centers for patients with advanced illness, but is very high risk. And then the last thing is that the nutritional deficiencies that are associated with cardiomyopathy in developing nations include thiamine, vitamin D, as well as selenium. These are my references. And then I just want to give a thanks to several people, including Dr. Naeem, as well as the authors of the cases that I presented. And then the last thing is the Grady Cardiology faculty, including Dr. Nora, Dr. Tamala, Dr. Mozami, as well as Dr. Hirsch, who all were very instrumental in discussing the case. And we had a lot of discussions at Grady about it. And I just open it up to any questions or comments people may have.
Rahul, thanks. Very good review, interesting topic. And I guess my question, probably not a lot. I don't know if you came across much data or case reports of like transplant in this in this particular group and how they do, and if it recurs, anything along those lines.
Yeah, it's like very anecdotal. I think the issue that you have with it is there are case reports of people having cardiac transplantation, but you're limited by several things. Like people are only going to publish good news as opposed to bad news. Recurrence, I would think, would probably have a low risk because typically people, I guess it depends on what the substrate is. If they go back to where they grew up, then it might come back, but then you're really damned because I don't think they're going to get a prograph level there, you know? And
Yeah.
so it's a little challenging where you really require people to leave the areas that they grew up in and live in a very different part of the world or their country. And therefore the evidence is just not very good. There's just case reports that some of them say that there's high risk, some of them say that they've had one good case here and there.
Yeah.
And I think you have to really screen well for pulmonary hypertension, especially for the right ventricle predominant one. That could make cardiac transplantation, quite limited for some of these patients.
Yeah.
Hello.
Yes.
Hey, Robbie.
Hey, Dr. Clemens.
Rahul, that was good. I would say Dr. Hirsch used to mention this disease occasionally, and he also used to mention, I may not be remembering this correctly, but sometimes people with congenital aortic stenosis of one kind or the other can have a form of this endocardial fibrosis. I may have seen one patient one time that was his that had that condition. Number one. Number two, I couldn't help but notice on your initial presentation that you were talking about mitral stenosis. Then you mentioned a holosystolic murmur, right?
Correct.
So what was that due to? I didn't see anything it could be due to unless it was that Garbodi-like defect. And I will tell you, mitral stenosis can have such a loud rumble. Sometimes you can get systole and diastole mixed up, and there can be a loud diastolic murmur that you don't pay careful attention to, and it's it's like AR or something like that, and you get all mixed up with it. Was there a reason for there to be a? You can think about that question if you like.
My thought is she may have had self-valvular aortic stenosis from like the interface between the bisympathetic strut as well as the LVOT. And that's
I can tell you that if she'd had that, she'd have turbulence in her LVOT, number one. That can cause a loud murmur. And one of the problems with these prosthetic valves is you see the orientation of that valve has oriented toward the septum.
right.
That's the opposite direction from where blood naturally flows into the heart. It flows down inferiorly, then comes around in the apical four-chamber view. It flows in laterally and comes around and lines up with outflow, which is a natural way for it to go. But when we put in prosthetic valves like that, that strut is very close to that. But most of the time, that does not cause a significant obstruction. But that's just my comment about that.
Yeah.
And so I thought you were going to show me TR with hypertension to have a holosystolic murmur, or I thought you were going to show me some sort of associated MR. But otherwise, you might have trouble explaining that holosystolic murmur.
Yeah, we struggled to visualize because the RV is so challenging to visualize. On an echo, it's really hard to fully capture the TR. And that could have been it, but you
can TR is an interesting murmur because the more TR you have, the less the murmur is. And as a matter of fact, with torrential TR, you don't even hear a murmur, and you hardly hear a murmur with TR unless pulmonary hypertension is present. So when you listen to a heart and you hear a murmur, say, well, that might be TR. Well, if you're hearing TR, then the pulmonary hypertension is present. There's a big gradient between the RV and the right atrium. Then the Garbodi defect is, if you're studying VSDs, you need to study about Garbodi defects. They are congenital defects, and they do result in a shunt from the left ventricle and the right atrium, and they shoot a jet up in there that can cause confusion in measuring the gradient, the systolic gradient across any the tricuspid valve is in a TR and make you think that pulmonary hypertension is present. I've had them come to my office with a diagnosis of pulmonary hypertension, and all along they had something like a VSD and didn't have pulmonary hypertension, and the louder the murmur, smaller the defect, and therefore say, forget about it, you don't have pulmonary hypertension, you go ahead and get pregnant and have a child. So just a few comments about that. It's a very, very interesting situation with endocardial fibrosis and mitral valve disease. Of course, hypereosinophilic syndrome, when it scars down, can pull on the mitral valve and cause, it is one of the causes of mitral stenosis. You say, name all the causes of mitral stenosis, which you'll encounter that list one day, and it's pretty long. But endocardial fibrosis associated with hypereosinophilic syndrome can cause that also. All right, thank you.
Thank you.
Any other questions from the group?
Yeah, I just wanted to say I thought that was a masterful presentation. It was interesting. You showed a lot of imaging, which you showed very well. A lot of information. It's smooth. It just, there was flow to your presentation. All I can say is well done.
Stan Sherman, first of all, congratulations on, you're now an expert on a disease that hopefully you'll never see again. Second of all, I was just wondering how the patient's doing, and is there plans for all that fibrosis in the right ventricle?
She's doing better. I think we need to have a more comprehensive discussion about her EMF. And so we don't have a plan yet, but we'll have to talk about it further. It's a very recent case. And to be honest, we were focused very, very closely on the bacteremia. But no plans for now, but it will require a in-depth conversation.
Well done.
All right. Well, thank you. And yeah, I agree, Rahul. Great job. Fantastic presentation. And thanks to all that helped him. And thanks everybody for showing up this morning. And we'll see you next week.
Thank you all.
The preceding program is copyrighted by Emory University.